In this unit, our lecture is on the final social determinant of health, and that is access to health care. As we go over the lecture, it should become very obvious to you that all of the other social determinants of health have an effect on access to care. So there are lots of different items we could discuss in relation to access to health care, but in this lecture, we're going to talk about access to health care, access to primary care, and health literacy as three major features in this lecture. So in regards to access, there are typically two types of questions that have to be answered. The first is, are services available? That means, are the services nearby? Are they there? Sometimes the services are not even present in the community. And then the other question is, are the services accessible? Sometimes the services are there, but people are not using them because they're not accessible. And we'll spend some time talking about what makes something accessible. So in regards to availability, the questions that have to be addressed in the communities are there enough healthcare providers within a reasonable distance to the community? Are there enough preventative services within a reasonable distance? Have facilities and services been closed within a community? Sometimes in more recent history, that's been related to family planning clinics that have been closed for a variety of reasons. And then, are there enough providers and facilities to serve the community? Typically, the rural and urban communities are the ones who may not have enough healthcare providers or healthcare facilities for different reasons, but they both suffer that issue. They both typically have higher rates of poverty and oftentimes greater rates of ethnic and minority populations. There have been policies that have been put into place recently that have attempted to close reproductive clinics, which has affected people's ability to get to clinics. If someone has to travel 300 miles to get to a contraceptive location because they're a medical assistant and that's the closest one, that then affects how available the services are to them. And then oftentimes practitioners prefer not to work in highly urban or highly rural areas. So because of that, there are fewer healthcare providers. In this slide, what it shows is how often people have financial means or insurance to pay. Because all the literature shows us that if people have the financial means to pay for healthcare, they're more likely to participate in healthcare. Those people who are uninsured typically have less access to funds to pay for it. So one of the critical issues in all the slides we're going to review is that in March of 2010 is when the Affordable Care Act was passed. So there should be a difference in what we see starting in 2010 with who has access to health care. So in these slides, you can see private insurance, public insurance such as medical assistance and Medicaid. And then right here, once Affordable Care Act went into place, we saw a slight decrease in the number of people who were uninsured. This slide shows you changes in the percent of people not insured by income level for 2010, 2014, and 2018. And you can see in 2010 how high the uninsured rates were and how they decreased. So people living in poverty, their uninsured rates have decreased since Affordable Care Act. People living near the poverty level have decreased. And people not in poverty or near poverty, their uninsured rates have also decreased. And the major reason why this has occurred is because of the Affordable Care Act. These next few graphs show you the same information, but in a visual format in slightly different years. So this shows 13, 14, and 15. These are the last years prior to the current political administration being in place. So what we see is, for these 3 years, the number of poor people who were uninsured decreased, the number of near poor people who were uninsured decreased, and the people who were not poor, they also decreased in uninsured rates. In this slide, what you're seeing is the percent not insured by race ethnicity. And so again, Hispanics have decreased, not Hispanic blacks, not Hispanic Asians, and not Hispanic whites. All racial and ethnic groups have decreased in the uninsured rates since the Affordable Care Act. So these are the changes between 2010 and 2018. Same information, but now in a narrative format. We know that medical care increased for poor and near poor. They had usual places to go for medical care, which usually means they probably are participating in primary care. The percentage of adults who talked to a health provider or had seen a health provider in the last 12 months increased for both poor and near poor. And the percentage of adults who did not obtain needed medical care due to the cost in the last 12 months decreased for all three economic levels. These are critical pieces of information when you think about women's health. Many times women are living in less economically stable situations. They're more likely to be poor or near poor, and we can see access to medical care has increased to women, and poor women in particular, since the Affordable Care Act has gone into place. These next few slides show this same information in a visual way. So here we have poor and near poor. They have increased in the percentage of them who have a usual place to go for care. And as you can see, there's really no change in the not poor population. In this figure, we can see that for adults who have seen or talked to a healthcare professional in the last 12 months, there's been an increase for poor, increase for those living near poverty, and basically no change for those who are not poor. And finally, this slide shows the number of people who did not obtain medical care due to cost over the last year. So over the 3 years, 13 to 15, you see a decrease in the poor, a decrease in the near poor, and also a decrease in the not poor. So these are pretty big differences in the number of people who did not seek medical care because of cost. Again, this primarily is due to the Affordable Care Act, and these are the last 3 years prior to the current administration. This right here is the link to take you to the data that you've seen on this slide and the slides just prior to this one. In this slide, what we have is access showing adults 18 to 64 that they've visited the emergency room in the past year in 2013 and 14. And we're going to talk about why that's important. This is important because what research tells us is when people do not have medical insurance, they do not have financial means to see healthcare providers, they typically wait until they're extremely sick before going to seek medical care. And the way they seek it is often in emergency rooms. So when you have people visiting emergency rooms, that's an indication they're not accessing primary care or preventative care. So here's the overall total. Here are people who have private insurance. These are the people who are on medical assistance or Medicare. Medicare being as if they were disabled, because after 64 is when everyone goes on Medicare. And then these are the uninsured. But you can see that those people with public assistance and those people who are uninsured have much higher rates of utilizing emergency rooms. And this is not good use of healthcare dollars. It costs much more money to visit an emergency room than to visit a primary care provider routinely, or if you're sick, to call your primary care provider for treatment. This shows no access to other providers rather than primary care providers. Again, we see very few private insurance people have lack of access to other types of providers. And then this shows the Medicaid and uninsured people who do not have access to other providers in those 2 years of 2013 and 14. This is a visual map. I think the visual map of the United States shows some very interesting trends of where everything occurs. So these are people without a usual place to go for medical care. So the dark blue and the light blue or purplish color, those are the states that have the highest number of percentage of people that do not have a usual place for medical care. And so each one of these locations has different reasons, and I'll talk about, I think, 3 of those. First, you have Alaska. In Alaska, everything is very far away from each other. It is a territory of the United States that's not well developed. And because of that, healthcare providers are going to be very far away from the population. That's just the way it is in Alaska. So that could be a reason why they have such a high percentage rate of people without a regular medical care facility. In Florida, a reason that could be high is because of the high numbers of people who are retired, and they may not have a usual medical place because of being retired, and moving there, they may not have established regular medical care facilities yet. In California, which is one of the second highest places, they may not have regular locations for medical care because the high level of poverty and minorities and ethnic groups that live in California. Those all present different reasons why people would not have a usual place of medical care. So those are just 3 different states and possible explanations as to what's going on. This is the map of the United States who show people have not seen or talked to a general doctor in the past 12 months. Again, some of the same states with the same high colors. Again, each state has different reasons, but still you see that mostly the Northeast of the United States has very different health practices than part of the rest of the country. And that's really important when you look at health status in those states. Excuse me. This link takes you to where all the data came from this slide and the few prior slides. So if we were to summarize how access is related to women, in most cases the disparities in access are greater for women. And that's because of how they relate to the other social determinants of health. When you think back to the other slideshows that you've watched, women typically have less income stability or economic stability because we know women make less per hour than men. Women overall make less money than men. Therefore, they typically have less access to health insurance and they have fewer funds to pay for health care. Education in some cases, so in certain ethnic or racial groups, education is not seen as a priority. And if you look at certain populations like teen parents, we learned that most of the girls who are teen parents are not likely to graduate high school. So that also then would affect their access to health care. In regards to environment and community, based on where you live, and because a lot of women live in poverty and a lot of single-headed women households are living in poverty situations, they are typically living in communities that may not have access to health care. And finally, the whole aspect of social context with race, ethnicity, culture, discrimination, all of those issues relate to whether or not people actually utilize health care in their communities. So these are major questions, and we're going to talk about each one of these in the next few slides. But these are issues that typically relate to accessibility, money and insurance, which have been most of the prior slides, access or transportation, cultural competence, sensitivity, facility hours, and the way the materials are written. So let's talk about each group of those now individually. So in accessibility, do people have the money, insurance, or means to pay for health care or treatment? We've spent most of this slide presentation talking about who does not have health care. And that's critical because if they don't have the money or the insurance to pay for health care, it's not likely that they will be utilizing primary or preventative health care services. Then, particularly in rural and urban communities, there is oftentimes transportation issues. In rural communities, there may not be transportation because there definitely is no mass transit. and there may only be one car per family, and everything is so far away. In urban areas, the transportation issues are often related to the utilization of mass transit and how realistic that is. If a woman has 3 kids and she's trying to get to preventative care, and it takes her an hour with 2 buses to get there, she's not very likely to utilize health care. In regards to accessibility and competence and culture, oftentimes healthcare providers are not culturally competent. They don't understand special health needs or issues in relation to certain populations, and they don't know how to relate to certain populations. So, for example, most healthcare providers are not aware of the special health needs of lesbian, bisexual, and transgender women. They don't know how to handle them, they don't know how to talk to them, and oftentimes there's a barrier that's created that this group of women do not want to utilize healthcare. In regards to racial and ethnic competence, oftentimes healthcare providers are not the same race or ethnicity as the people they're providing services to. And if they do not understand the cultures, then that means they are not very likely to be able to reach the population. They don't have to be the same race or ethnicity, although that helps. But if they're not the same race or ethnicity and do not have a strong comprehension of how that ethnicity or race works, they are oftentimes rude, abrasive, and disrespectful to the cultures. Once that happens, then those people are not likely to participate in healthcare. There are also several studies that have occurred based on how the healthcare providers have mistreated poor people. If you think back to the very beginning when we talked about how slaves were treated and poor women were treated by healthcare providers. And then you have the Tuskegee report. You have other issues that have happened in more recent history where consistently healthcare has not treated minorities and poor people respectfully. So that further causes issues. And when you look at all of those and combine them with what the social determinants of health say, if the providers are not culturally competent, typically people will not utilize the services. So the service could be there. It could be a block from the person's home, but they may choose not to use it because of these issues. Then the next level is cultural sensitivity. Are the reading levels at the right level? So if English is if it's not their primary language, they may read very well in their own language, but that doesn't mean they read well in the English language. If you're talking about people who live in poverty and have not completed school, they may have very low reading levels. And if material is not written in the person's primary language, it makes it more difficult to read. So again, services may be there, but if they cannot read the material and they don't understand the material, then there's lack of health literacy, and then that means they're not going to utilize services. And then accessibility, especially for women, this becomes very important, is what are the hours of the providers and facilities, and are the services family child friendly? So if you're talking about a woman who lives in poverty and she's a single parent, or she's living near poverty and she works 1 or 2 jobs to try to make ends meet, if the facilities or providers only have hours Monday through Friday from 10 a.m. to 2 p.m., that service is not accessible to her. And if the services are not family child friendly, she's not typically going to use those services. So if she's trying to get preventative care for herself, but she has to take her 3 children with her, and there's no place for the children to play, and people give her dirty looks because there are children with her, she is not likely to utilize those services because she doesn't feel welcome there. So if we wrap up the social determinants of health, it should become very clear to you that these are all very closely related to each other, and each one is somehow related to the other. All of them are very distinctly related to access. And for all of these social determinants of health, they have very unique relationships to women and how women then utilize health care. So what's next for this unit? You should read the other material in the lesson and review the web links. In the lesson 1, there are a few readings and web links. Most of them are very general. But in lesson 2 for this unit, I've chosen very different items related to your topics. Feel free to only read the ones that are most related to your topics, or feel free to read as many as you have time for. Continue to gather and read articles related to Access and your health topic for the semester, and make sure you complete all the assignments on time. Good luck with the unit. I hope you enjoy it, and I look forward to reading your work.